basically, as you know, before the era of new monoclonals and before the era of MRD, or at the beginning of the era of MRD use in ALL transplant, a meta-analysis in standard risk ALL showed that allogeneic transplant is better than other approaches. That was a donor versus no donor comparison, and 5-year survival was 55% versus 45%. And this was mainly due, or at least due to a well-documented graft versus leukemia effect in ALL, where you have patients who develop a graft versus host disease will have a lower relapse rate and better survival after transplant. However, as you know, there are many patients who relapse after transplant, and also we have toxicity and non-relapse mortality associated with allogeneic stem cell transplant. And it's actually a very large and topic that would be difficult to cover in a few minutes about all the progress, how to improve allotransplant outcome. Actually, there are strategies to reduce the transplant-associated toxicity and non-relapse mortality by selecting patients based on age, comorbidities, conditioning regimen, graft source, strategies for prevention of graft versus host disease, as well as progress in supportive care. However, I will be more focusing about strategies to reduce post-transplant relapse, mostly based on the use of MRD before transplant, and consolidation and maintenance strategies after transplant. So as you know, from a very large meta-analysis that included more than 13,000 patients with all ALL subtype, the prognostic impact of MRD clearance was consistent across therapies, MRD method, timing level of cutoff, and subtypes. And actually, MRD identifies candidates for allogeneic transplant, and indeed patients with molecular failure who underwent allogeneic transplant had significantly better disease-free survival than those who did not. So MRD now is widely used to put the indication for allogeneic transplant in patients who remain MRD positive and therefore are called molecular failure. However, we have to understand the impact of MRD on outcome after allotransplant, and from multiple major published trials, patients who are transplanted MRD negative have a better outcome than patients who are transplanted MRD positive. And this better outcome is mostly due to a higher rate of relapse after transplant in patients who are transplanted MRD positive. And this may suggest that we have to treat the MRD prior to allotransplant to convert patients who had molecular failure from MRD positive to MRD negative before proceeding with transplant. And one strategy to achieve that goal is to use Blinatumomab, a bispecific monoclonal antibody, BiTE antibody, and actually that has been shown to convert around 80% of MRD positive patients to MRD negative status after one cycle of Blina. This was mostly demonstrated in the BLAST trial. However, and this is the paradox in this trial, there was no difference in overall survival and relapse-free survival between patients who underwent allotransplant versus no transplant after receiving Blina, though 78% of patients included in this trial received allotransplant. And actually, when we're talking about strategies to reduce relapse, this is mostly because of the dismal outcomes of relapse ALL after allotransplant, with a median survival of few months only for most patients. Although these are encouraging results, we recently showed in a large EBMT acute leukemia working party study published in Clinical Cancer Research that the overall survival after relapse in Philadelphia positive ALL had more than doubled in recent years. And actually, one strategy in Philadelphia positive ALL that pioneered consolidation or maintenance treatment post-transplant is the use of tyrosine kinase inhibitors as post-transplant maintenance in Philadelphia positive ALL. And a nice paper by Pfeiffer in 2013 showed that a prophylactic imatinib approach, so you're giving imatinib post-transplant to everybody, achieved a better MRD duration of molecular remission as compared to an preemptive approach, which is to give imatinib once patient develop MRD positivity post-transplant. And actually, these results were later confirmed in the EBMT registry by Eolia Brisso, showing that in multivariate analysis, TKI maintenance resulted in significantly better leukemia-free survival and overall survival. The most frequently used agent were imatinib followed by dasatinib. And similar results actually from the MD Anderson Cancer Center showed better survival for patients who received TKI post-transplant. And actually the duration of TKI matters, whereas patients who receive more than 2 years will have better survival compared to patients who received less than 2 years. So can we apply this concept to other ALL, for example, Philadelphia negative ALL, and can we use Blinatumomab maintenance in that setting, which is the ideal drug? And actually, this was a study that was performed on 21 patients in the MD Anderson Cancer Center, high-risk B-lineage ALL, who received prophylactic post-allo Blina. 57% of patients completed 4 cycles of Blinatumomab. Treatment was overall well tolerated, and with a median follow-up time of more than 1 year, overall survival and progression-free survival were 85 and 71%. However, compared to historical control, there was a numerical improvement in PFS and overall survival that was not statistically significant in that study. And finally, we have some encouraging preliminary results in T-lineage ALL. This is the orphan disease where little progress has been made, T-ALL. And in that setting, because of multiple epigenetic mutations, strategies using post-transplant hypomethylating agents such as 5-azacitidine or decitabine, similar to what has been used in AML, were tested and were the most promising results were in the setting of T-ALL, and actually at the American University of Beirut in Lebanon, we have very nice preliminary results using azacitidine with or without venetoclax in 5 patients with T-ALL as prophylactic post-transplant approach. All of them are in complete remission and up to 21 months post-transplant. So in conclusion of my talk, despite achievement of CR, up to 60% of patients with ALL may still be MRD positive, and this is predictive of worse survival on chemotherapy. And this MRD positivity can therefore define indication for allotransplant. Pre-transplant MRD positivity is a major risk factor for relapse, but the role of Blina, we're not sure that we know that Blina can convert patients to MRD negativity, but not sure if this will improve survival post-transplant and if transplant is still indicated. And finally, for consolidation or maintenance strategies post-allo, it is standard of care in Philadelphia positive ALL, and we have encouraging preliminary results of Blina in Philadelphia negative BALL and hypomethylating agent in TLL. Thank you for your attention.